Okay, good morning. This is Dr. Puryear. For the sake of time safety, for time's sake, I'm going to just give this presentation and record it as a video, posted that way you're able to watch it whenever you're able to. You can watch it, pause it at your own speed. You can take notes. Now, I have posted the PowerPoint slides. These are PowerPoint slides that I created, so you're not going to find them anywhere else, but I posted them in your resources folder of Blackboard. I've also posted the PDF of these PowerPoint slides, and so you're able to print that out, follow along, and take notes. You'll notice cardiovascular is probably one of the most complex chapters that we cover in pharmacology, and in particular, it's because if you look at the top 25 drugs, 18 of them are all drugs related to hypertension, high cholesterol, or cardiovascular related. And so these are the drugs you have to know, the drugs you need to know. It's one of the reasons why when we work on these drug cards, learning the drug endings, identifying the main or the significant side effects, the main considerations, the main warnings. Once you learn it for one, you pretty much know it for an entire group. The other thing is, we're not wasting time on trivial information. We're learning things that are significant, things that are information that you need to know as a technician, things you need to be able to recall or remember when you're taking it to pass the PTCE exam, which is really the greatest, you're preparing, that's going to be your greatest obstacle. So completing the program and earning your diploma, that's a huge step. That's incredible. But unless you're able to pass the PTCE, you're spinning your wheels, you're wasting your time. So this is to make sure that you're prepared. 40% of the PTCE now is pharmacology, and then we know the kind of pharmacology that's on there. It's going to be side effects. It's going to be the things that are so common in a class of drugs that a technician would be expected to remember it. Just one point I'll make and then I'll get started. I've had classes before, I'll ask them, we finish a sequence. When we start the new sequence, I'll give them a blank sheet of paper and I'll say, write down every drug you can remember that we covered last sequence. Let's start with the drugs you were tested over. Write down the brand, generic, indication, side effect. People draw a blank. We'll see, when you're in college, when you're in school and you're learning something, you're learning it to become a professional, healthcare professional. What differentiates you from anybody who can just pick up a phone and Google something to find out the information? Well, it's you're learning this information, you're retaining it, you remember it, you know it. But that requires work. It requires devoting time and energy to studying and memorizing. It also, that's the whole reason we devote so much time to these drug cards. Speaking of the drug cards, one thing I wanted to mention, ordinarily when we're on campus, every couple of days, I would take all the students' drug cards and just redistribute them. Nobody knew whose card was whose. And then we would talk about the cards. People would point out what they really liked about a card or what they found missing in a card. They could share where they found their information, how they approached the cards. We're not able to do that in the distance education, but one thing you can do is reach out to your fellow classmates. Several of the students have created drug cards that have just been amazing. They're the best that I've seen. And then other students are still struggling with trying to understand where to get the information. I will tell you this, you're not going to find all the information in one quick, easy, convenient spot. I recommend starting with your books, your pharmacology, or your certification exam review. Find the drug. What's its indication? You're going to find that they will spell out the most common side effects, the most common considerations. That's where you find that information. Then you can go fine tune it on the internet or in your drug information handbook as far as exactly what strength and what it's prescribed for. And I've had some of the cards turned in, and a drug might be used like very, very rarely for a condition, but I've had students turn them in and like that's the only condition the drug treats. And then it just tells me that there's not they're not being researched. It's just finding a site, finding information to scribble down and moving on. just keep in mind, this isn't just about doing an assignment, turning it in, and getting the credit. It's a learning process. When you do an ACE inhibitor, when you complete an ACE inhibitor, by the time you're done, you're going to remember they end in PRIL. You're going to remember they're used to lower blood pressure. You're going to remember that they also help protect the kidneys in diabetics. You'll remember that a very unusual side effect, it can cause a continuous dry, persistent cough. You'll learn that it can raise your blood level of potassium. That's a big deal. When your potassium is elevated, it can make you more predisposed to having a seizure or a heart attack. So you have to monitor. And you'll learn that you can't take it if you're pregnant. And once you learn that about the drug that you're doing, guess what? It applies to all of the ACE inhibitors. So you haven't just learned all this information for one single drug. You've learned it for a whole group of drugs. It can be 7 to 9 different drugs. So if you don't learn it for the one drug, you're not learning it for any other drugs. If you do learn it and you learn it correctly for the single drug, well, then that relates to the other drugs in the same class. So let's get started. This is the cardiovascular system and pharmacotherapy. Again, reach out to your classmates. Just ask them if they can send you a photo or two of their drug cards and look at what they're doing. You can show them what you're doing and share ideas. Once we're back on campus, it'll be easier. When I'm able to work with you individually and take a card and stop you before you proceed and say, no, let's go back and let's start over with this card. It's much easier. It's still just kind of a challenge learning how to adapt to this distance education. So it's the cardiovascular system. Here's a pharmacotherapy. We start out with this cardiovascular system that circulates blood throughout your body. It brings oxygen and nutrients to tissues. It also carries away carbon dioxide and toxic byproducts. So carbon dioxide is poisonous to our body. We need oxygen. Our cells need oxygen to thrive and survive. But when you use the oxygen, the byproducts, carbon dioxide, it has to be removed from the system. So circulatory system is how we distribute it and remove it from the body. Arteries carry blood away from the heart. Veins carry blood to the heart from tissues. Excuse me. Capillaries are tiny blood vessels, and the capillaries are where fluids, gases, and nutrients are exchanged. So this is just an illustration you can see. You've got the lungs, you've got the heart. You can see where you've got oxygen, where it's red, the red oxygen-rich blood circulating throughout the body. Then whenever that oxygen is used, you've got carbon dioxide, it's coming out of the heart in the blue, it goes back to the lungs where it's expelled. So what are the causes of cardiovascular disease? There's two different considerations. One is predetermined. These are factors you have no control over. So it's just a matter of genetics, heredity. So there's some genetic traits that you're just born with. You can't help it. It's just in your family's makeup, genetics. Gender, men versus women. Men tend to have more cardiovascular issues than women. And then increasing age, as you get older, you're more vulnerable. And in essence, your cells, they're not replicating the same as they do when you're very young and developing, and your cells, they get worn out. Just like anything, if you buy a piece of equipment over time, it's not going to be functioning as well as it did when you first got it. The factors that are influenced by lifestyle modification, these are factors you do have control over. And you'll notice if people really had a genuine appreciation of how cardiovascular disease can impact life, they think twice before vaping or smoking cigarettes. Even think twice about their diet, what they're eating, their weight. Do we need to get up and exercise more, move around? Do we become more sedentary as a society? Smoking cigarettes. If you have high blood pressure is called a silent killer. And it's called that because with high blood pressure, you do not really have symptoms. You don't know you have high blood pressure. So a person can have high blood pressure for years before it's discovered. If you discover it and get it under control, that's much healthier for your heart and your cardiovascular system in the long run. High blood cholesterol, the higher the cholesterol, your cholesterol, it binds to the arteries and veins and hardens. It causes atherosclerosis, and as they harden, that makes a narrower passageway for your circulation. So you want to have your cholesterol under control. And it's something else, unless you're tested for it, you're not going to really know where your cholesterol level is. Obesity and diabetes. So what's angina? Angina pectoris. Angina is whenever you're not getting enough oxygen to the heart. Your heart muscle needs oxygen. It needs the oxygen as a source of energy and to thrive. And if it's not getting enough oxygen, you actually have nerves that are in the heart that send a message to the brain and start sending messages of discomfort and pain. With angina, there's a difference between angina and myocardial infarction. Angina just means you're not getting enough oxygen to the heart, but there hadn't been permanent damage. With angina, you'll feel discomfort, but as soon as you get the situation corrected, once you get that oxygen flowing to the heart, then it should be reversible back to normal. These are just 3 different types of anginal. There's stable anginal, unstable, and variant. And then there's actually about 12 different varieties within these. Y'all don't need to worry about that. So what are the symptoms? The main symptoms: chest discomfort, then sweatiness, dizziness, dyspnea. Dyspnea, that's just difficulty breathing, kind of like if a fish is out of water and you see it gasping. It's very often it's triggered by exercise. It can also be triggered by emotional stress. The risk factors: as you get older, you're more vulnerable. Coronary artery disease, that's where you have hardening of your arteries. Your arteries are narrower, so you don't get the same or adequate circulation or perfusion of the heart. Hypertension, which is just high blood pressure. Increasing glucose, that's diabetes. Increased lipoprotein, so that's just like high cholesterol. Obesity, smoking, and a type A personality. And type A personality, I think most of y'all are familiar, but that's somebody they're very high strung, very meticulous, detail oriented. They kind of press themselves to be the very best and to always be on time and always have everything just right and just perfect. And if it's not, they blow a gasket. So they create just a lot of stress for themselves. So what drugs do we use for angina? We use beta blockers, and you'll notice beta blockers, they end in OL. So it's kind of like laugh out louder, but beta blockers, OL. We use nitrates. Nitrates, they have NITR, like the word nitrate. Calcium channel blockers. Now we have older ones. There's one called verapamil. There's one called diltiazem. But all the rest of them, they end in dipine. When I worked at CVS, this old lady came through the drive-thru and she kept saying she needed her dipine medicine. I was looking for pain medicine. I thought she was talking about dipine medicine, but she was saying dipine. Dipine is a calcium channel blocker. And then the metabolic modifier, Renexa. I'll tell you how these work in just a second, but this is kind of a very, very last resort. Very expensive, and it's a last resort. So the beta blockers, how do they work? Beta blockers, if y'all remember, beta blockers, we have beta receptors for our body, and we have beta 2 receptors. Well, we have 2 lungs, beta 2s in the lungs. We have beta 1 receptors in the heart. There's one heart, beta 1. By blocking a beta 1 receptor, we help slow down your heart rate. So a beta blocker helps to slow down your heart rate. When you slow down the heart rate, your heart's not pressing blood through the system with such a force. By doing that, it decreases your blood pressure. And then myocardial contractility. Myo is the word for muscle. Cardio refers to the heart. Contractility just refers to a muscle flexing. So whenever the heart's flexing, whenever it's pumping, it's not as pumping as hard as it had been. It helps to slow it down. And it's actually through decreasing the myocardial contractility that it decreases the heart rate. How does it do it? It blocks primarily it's blocking beta 1 receptors on the heart. And beta 1 receptors on the heart, they're stimulated by epinephrine or adrenaline. So when you have a beta blocker, it blocks those receptors from being stimulated. So you think about epinephrine or adrenaline, We have the fight or flight response. If you're terrified, you get this burst of energy to go running or to put up a fight for your life. Well, think of what that does to the heart. It makes the heart uh, start pumping harder, faster, quicker. By being able to block these receptors, that's how you help slow it down. Now, here's just two examples. You'll notice they end in OLOL and carvedilol is the IL, but these are the most common two that are used for angina. You're going to find a lot of drugs, they not only work to help with your heart for angina, but they also lower blood pressure and they have additional benefits. Carvedilol is the most significantly prescribed beta blocker for congestive heart failure, for angina, and for blood pressure. And then we've got metoprolol. This is an older one, and you're going to find with metoprolol, we have two different types of metoprolol. One is metoprolol tartrate, and one's metoprolol succinate. The metoprolol succinate's nice, you just take it once a day. I'll cover that in just a minute. Here's just more examples. So you can see this is an example of whenever you do a drug card, and you have one drug card, let's say it was over carvedilol, and so you got the OLOL, it's going to turn out that the side effects, that the contraindications, the indications, use in pregnancy, it's all going to be virtually the same. So when you do it for one drug, when you learn this for one drug, then all of a sudden you got 1, 2, 3, 4, 5, 6, 7, 8, 9, and there's actually more. Now here's the most important thing. This is the message you need to remember with your beta blockers. You do not discontinue abruptly. If a person goes 2 days or 3 days without taking their beta blocker, there's a rebound effect and they can have a heart attack. All the benefits of taking the drug, it's undone. And then what you experience is much worse than before you even took the drug. So with beta blockers, you do not ever discontinue. In pharmacy practice, if a patient comes to a community pharmacy and they need to refill their medicine, let's say I have a prescription for carvedilol, I bring it in to refill it and they say, oh, you don't have any refills. It's a Friday, the doctor won't be back till Monday. Well, that's how the law allows the pharmacist to loan me 3 days worth of medicine. Because if I went without the medicine for 3 days, then I could end up having a heart attack or dying. So you never, ever just immediately stop taking the dose, whether it's intentional or because you run out of medicine. Nitrates. Nitrates, they have NITRO, and how do they work? They relax the vascular smooth muscle, and it allows more oxygen to permeate into circulation, from the circulation into the heart muscle. It's used for an acute angina. It's also used for prophylaxis. So an acute attack is whenever somebody's mowing a lawn and then they just hold their hand up to their chest and, oh my God, I'm having a heart attack. That's a sudden and acute. Once somebody has an angina, an episode of angina, it's likely they're going to have it again in the future. So doctors will put you on a drug to help prevent you from having another attack of angina. The nitrates are used, so you'll use that during an acute sudden attack. You also take them regularly to prevent. Now with nitrostats, you're going to find there's a nitroglycerin patch. You put the patch on every morning. You take it off at bedtime. There's nitrobid capsules. There's ointments. And then we have nitrostat tablets. But with nitroglycerin, your body has to have an 8-hour drug-free interval. Part of how they work, it requires a depletion of sulfhydryl groups. And if you were to wear a patch and you were to leave it on 24 hours, at the end of that 24 hours, you've depleted your sulfhydryl groups. And so the next day when you put the patch on, it's not going to work. So just remember with the nitrate, in particular the patches, they're only worn for, you take them off for 8 hours. Take it off, throw it away, the next day you put on a new patch. Here's just some examples, and you'll notice they all have NITRO, nitro, nitrostat, nitrobid, nitrodur, nitroglycerin. We also have isosorbide. Isosorbide, but then you'll notice where's the NITR? It's isosorbide mononitrate or isosorbide dinitrate. So there's that NITR. there's a life-threatening interaction. So this is something you've got to know. This will be on your PTCE. Any patient that's using a nitrate, any patient that's using it for an acute attack or using it for prophylaxis, they cannot take the erectile dysfunction drugs. These drugs, they end in a pill. First one to come out was Viagra, sildenafil. Then we have vardenafil, and now there's 5 of them, but they end in a pill. And the way they work, they cause your blood vessels to dilate so that they can fill it up, gorge it with blood. Well, you've got your anti-anginal drugs. These, what are they doing? They're relaxing the smooth muscle, and so it's going to allow further dilation. And what happens is the combination causes such a vasodilation. There's such a sudden drop in blood pressure that it can be life-threatening. Several hundred people have died just because they think, oh, this won't affect me. But any patient taking the nitrates cannot take an EDD drug. They identify. Here's nitrostat. This is a drug you need to know about. It's used at the onset of a heart attack. Once again, it dilates blood vessels to allow more oxygen to get into the heart. It's sublingual. So if a person's bilingual, bi means two, lingual is tongue. Sub means under, lingual is tongue. Sublingual goes under the tongue. They come packaged in bottles of 25. It's got a metal screw cap, amber glass, and a doctor can write for a single bottle of 25, or they can write for a box. And this is a box with four little bottles of 25. The way it works, at the onset of angina, the patient places one tablet under the tongue, wait 5 minutes. If you still feel the distress, you put a second tablet under the tongue. You wait 5 minutes, it's still in distress, you go ahead and put the third tablet, but by that point, you should be headed to the ER. The maximum dose is 3 tablets, so it's one under the tongue every 5 minutes. And so, for the most part, if somebody has to use more than one tablet, they need to follow up with the doctor. Now, here's what you need to know that's most important. We have the Childproof Packaging Act that requires most prescriptions be dispensed in a childproof container. Well, this drug is an exception. So why would it be an exception? Well, think about it. If somebody's having a heart attack with chest tightness, the last thing they need to do is to have to be struggling with a childproof lid trying to open the bottle. So it has to be in this amber glass. The amber glass protects it from light, and the tin cap ensures a special seal to prevent oxygen or moisture from getting into the bottle. Once you open a bottle, once the bottle's open, these little tablets are tiny tablets, and for them to dissolve quickly under the tongue, they're very fragile. So when you open a bottle, even if you only use one tablet, that bottle, the tablets that are inside, they're going to be breaking down over the next month. So once you open a bottle, it needs to be replaced in 30 days. So more anti-anginal drugs, we have calcium channel blockers. And you'll notice the number one that's dispensed in the United States is amlodipine. Diltiazem and verapamil, they're older calcium channel blockers. Then they came out with the dipines. Now we've got amlodipine, felodipine, isradipine, nicardipine. So you'll see all the D-I-P-I-N-E, dipine, calcium channel blockers. They prevent calcium from entering the myocardial cells, so they block slow channels during repolarization and depolarization. Main side effect is fluid retention and constipation. It's real important for the people taking these anti-anginal drugs. You cannot crush the extended or time-release formulations that disrupts your ability to release over time. And then several of these come in a tablet, but it's got a tiny, tiny micro, or a tiny hole you can barely see with your eye. The medicine's released through this hole. So when a patient takes a tablet, the tablet passes through their digestive system. And a lot of times patients will see these shells in the commode and they'll think that they're not absorbing the medicine, but it's just a ghost pill. It's the empty shell of the tablet. And so you can see right here, there's a tiny hole right between the O and the C. And then finally, we've got the metabolic modifier, which is Renexa. What this does, it enables the heart to continue working, just utilizing less oxygen. You have to be very careful using it in elderly or people with renal dysfunction. I'm going to stop here and I'm going to pick up the next part of the video with the anti-arrhythmia.